Please give yourself an applause. Welcome to the third and final day of the 2014 Colorado Health Symposium. I'm Shepard Nevel with the Colorado Health Foundation, and I hope everybody enjoyed the reception last night and the dancing. Quick raise of hand if you were there. Yes. You know, based on the very popular response to a particular song by Salt and Pepper, we thought we were going to have to change the name of the symposium from the Power of Engagement to the Power of Push It. But we decided not to. And you know, people kept encouraging me to go on the dance floor, and I was getting very flattered until I realized it was just part of a plan by our communications and evaluation teams to lower the baseline so that everybody else looked really good on the dance floor. So you all can thank me later. And where's Catherine Rosechild? Let's give a round of applause to our DJ, who's been doing double duty as our director of IT. And she agreed to play a lot of songs she liked and some she didn't in order to be responsive to the group. And of course, earlier in the evening, we were just thrilled to honor our 2014 Iglehart Award winner, Elizabeth Arnales. Where's Elizabeth? And like so many of us here, I've just had the great pleasure of working with Elizabeth for so many years, and you're just not going to find a more thoughtful, knowledgeable person who's so generous with her time and her expertise, and is just so invested in everybody involved in our mission succeeding. And so a wonderful congratulations to Elizabeth, and a wonderful evening last night. And I also want to acknowledge as well the outstanding panel of presenters we had yesterday. And you know, it's been suggested that I share a few highlights. And yesterday, Annie, as you know, encouraged us to galvanize our efforts around changing our built environments and our systems in a manner that will bring about transformational change to the healthcare landscape. And Lygia Ricciardi shared, you know, what I'm sure all of us found to be the very powerful story of her daughter's health issues and the profound decision that she and her husband faced, whether to have their young daughter endure open heart surgery. And you know, how the factors playing into their decision reflect on the strengths and weaknesses you know, in our healthcare system, even for those with the best access to care. And you know, for me and many others, you know, when she spoke about government as a catalyst and convener, avoiding a top-down approach, I thought that would be nice. And the innovation driving the Blue Button initiative, I found myself thinking that you know, this should be the new face of the federal government. And all four presenters yesterday spoke about how to make healthcare broader. You know, and one of, I think, the great values of this symposium, and we hear this so many times from so many of you, are, you know, the sidebar conversations that you have with one another. And last night about 11:30, I think it literally was a sidebar conversation. But you know, through those conversations and the ones here on stage, you can see the dots being connected that may not have been connected in quite that way before. So Stacy Pilata had us thinking about hospitals and empathy, not just as a theory or a nice thing to say, but as a deeply rooted value that actually shapes and defines their hospital operations. She also spoke about the tension between the push for patient engagement and the push for data protection, and the emerging alignment in healthcare toward common goals across a lot of disciplines. And Billy Wynn, I thought, did a terrific job talking about the ACA and the dangers of sugar. And you don't typically hear those two things together, but they should be, right? We should be talking about both of them in a more holistic sense. And he also spoke with considerable eloquence, I think, about the unintended consequences of not accounting for socioeconomic factors, you know, and how we evaluate health outcomes, you know, because what you measure and how you measure it really matters. And so he may have gotten a bit carried away talking about ACOs. I think he may actually have used the word love in referring to them. But we do encourage self-expression at the Colorado Health Symposium, so we think that's a good thing. Robin Shepard spoke about sick care and optimizing health and the need to reassess where we allocate our resources. The importance of nutrition and physical activity as part of medical training, and how we live in a time where we are shifting from a primary focus on changing federal policy, which she described, I think, very accurately as years of slogging through federal legislation, to a focus on what she referred to as little p policy, which I think really resonated with a lot of us, where consumers empowered by technology are driving change. And all of our presenters yesterday spoke about how consumers are starting to take over healthcare that a movement is afoot. And I thought that's a great lead-in to our focus today on community engagement. And I find it interesting that while confidence in federal government has plummeted over the past 50 or 60 years, most people still believe very passionately in their local communities and institutions. They care about their communities. You know, their dreams and hopes and creative energies are rooted in their communities. The Pew Research Center recently released a study that showed that less than 30% of Americans hold the federal government in high regard. That's a historic low. Think about that. Meanwhile, Americans give high marks, and the rate of support is growing to local governments, with 63% reporting favorable views, which continues, as I say, to increase year by year. And that is precisely where so many health-oriented solutions, public and private, are being cultivated and launched, at the local level. And while systems and behavioral models can, create a framework for a culture to change, it's the trusted voices among the communities, many of them are here, with integrity and commitment that engage their friends and their neighbors and their families to acceptance and demand its transformation. And one example, as Annie mentioned yesterday, I think, are the healthcare assistance sites that have engaged thousands of individuals in their communities to enroll in both public and private health insurance through our healthcare marketplaces. So these organizations and individuals, like the presenters we'll hear from today, often serve as the center of a community, providing needed services and functions that would otherwise be unavailable to populations. And in many cases, these community models are being replicated and adopted by the public and private sector and expanded nationally. And we see such extraordinary qualities in our communities, both by the work accomplished and in many cases acts of personal courage. As with one of our presenters today, Dr. Prabhjot Singh, who will be more formally introduced later this morning. But just to share one story, just 9 months ago, Dr. Singh was on an after-dinner stroll with a friend along Central Park North in New York City when he was a victim of a vicious hate crime. Attacked by a group of more than 15 assailants, he was punched and kicked repeatedly, his jaw fractured, his teeth knocked loose, his face and body bruised and bloodied. To this horrible experience, he and his wife, who was his co-presenter this morning, Mamit Kaur, responded not with anger or hatred in return or even self-pity. He seized this horrible incident in the media that it generated to issue a call for love, compassion, and understanding. And he said, and I quote, "Even more important to me than my attackers being caught is that they are taught." And this to me is, really heroism in its purest form. And it's as good a symbol as we can have of the spirit and grace and the generosity and persistence that drives change at the community level, which in turn can change a nation. So we are honored to have this extraordinary group of presenters to share their stories in their communities. And we are equally honored to have a multi-talented moderator whose impressive career spans local and national leadership. And it's such a thrill to welcome Dr. Anthony Aitan back to the Colorado Health Symposium. There's about 3 or 4 impressive lives in this one individual. He's a medical doctor, an attorney, a national leader in philanthropy, and a powerful voice for public health. He's a senior vice president of healthy communities at the California Endowment, where he and his colleagues are doing remarkable work that the rest of us, funders and others in this space throughout the country, are watching closely and learning from. So we're so grateful to you and to your organization for your leadership. Prior to that, he served as director of the Alameda County Public Health Department, where he brought his innovative leadership to tackling health disparities and the root causes, of poor health. He has also served as director of Health and Human Services and school medical advisor for the city of Stamford, Connecticut, while serving simultaneously as a primary care physician and staff attorney and health policy analyst for the publisher Consumer Reports magazine. Wow. He is a popular lecturer and keynote speaker and a frequently published author. And perhaps most importantly, he's widely recognized as an effective fighter for social justice. So please join me in welcoming Tony Aitan.
Thank you, Shepard. That was very nice. I appreciate that. I don't know about any of you all, but I got here last night, and my house is at 8 feet above sea level. And I am like delirious, like you all are like purple spots, you know, kind of floating in front of me right now. It's a real pleasure to be back here. I'm looking at my timer here to make sure I get my 30 minutes. Somebody else get their watch out to just make sure she's giving me an honest 30. It's really nice to be back here, although, like I said, I'm having problems breathing, I'm having problems seeing, and I still think I'm thinking okay, but you let me know, because I may start hallucinating or something, and God knows what will happen then. I want to set the agenda for today's panel by contextualizing community engagement and what the real purpose of community engagement is, and why community engagement is so critical to try to solve the kinds of problems that we're facing in health. Notice I didn't say health care. In health today in this country. And so I want to start by just sort of taking you through kind of a little journey that I and some of my colleagues have been on in trying to figure out the role of deep community engagement. I'm going to assume that this thing, is this what moves things forward? Yes, I think. First, I should say I sit on a number of boards and I work at the California Endowment, but I don't like being constrained by the people that I work for. So I always disclaim my comments and say that I'm speaking on my own behalf. I'm not speaking on behalf of, I sit on the CDC's Director Advisory Board. I used to work for the Alameda County Health Department, and I use a lot of that data. I work for the California Endowment, and I have a lot of other affiliations. I'm not speaking for any of them. I'm speaking for me. Okay, so this conference has already explored this theme. It's pretty well established in health these days that place matters, and that place and the environment in which people live deeply shape their health opportunities. And you know, this catchy phrase, does your zip code matter more than your genetic code? We've basically answered that question. But the next question then is why? Why does your zip code matter more than your genetic code? This is Alameda County, where we looked at life expectancy by census tract. There are about 150 census tracts in Alameda County. And we see about a 22-year life expectancy difference between the highest life expectancy census tract and the lowest life expectancy census tract. They're in the same city, Oakland, California. We've seen the same thing in Cuyahoga County, Cleveland, in Baltimore, Maryland, where they have approaching a 30-year life expectancy difference. Los Angeles, Seattle, King County. This is New York City. This has been replicated in a number of places around the country. This is Philadelphia. In Washington, D.C., you can actually calculate the life expectancy of people based on which stop they get off on the commuter train. So this is not at all something that's unsettled. We understand that place matters, and it matters significantly. We've done this in California. We've tried to sort of raise the profile of this issue. This was the American Public Health Association meeting held in San Francisco a couple of years back. And this is the Metreon building, for those of you who know San Francisco, which is sort of a big kind of like cool cinema and a bunch of restaurants. We literally festooned the building with this message, showing people that place matters. Okay, so we know that if you live in a low-income community across this country, many of them are park poor. And we ask people to exercise and to, stay fit. But these are the kinds of places that they have to play in, particularly young children. And then we're surprised when we see obesity levels. We know that many of our low-income communities are food deserts. And we tell people to eat well and avoid fast food. But then this is the environmental context in which they are asked to shop. And so the question for us is, why is this? Why do some communities have to contend with this over and over again in these very predictable patterns? And sort of what is the role of community engagement in addressing this? Many people look at community engagement as sort of like something that's nice to do. And I would argue that you are not going to solve these deeply seated inequities in society unless you engage people at a fundamental level. Because health is political. And when I say political, I say small p political. It's not Democrat, Republican, it's not partisan political. It's political by most definitions of politics. This is one. Politics is the struggle over the allocation of scarce and precious social goods. And when you're talking about scarce and precious social goods, you're talking about things like a park or a grocery store. These things don't just happen. People have to participate in local land use decision-making processes to decide where the resources locally are going to be allocated to benefit various aspects of the community. And for many years in this country, a whole segment of the population was kept out of those conversations, and it has health consequences. So if we believe that the solutions are ultimately political, there are certain ingredients that we have to attend to. We have to know that power matters. And that means political power, social power, economic power. These are determinants of health. We have to know that participation matters. People have to be actively engaged in decision-making forums. And that includes stigmatized populations like undocumented residents, ex-felons, LGBTQ, boys and men of color. We also have to know that narrative matters. The story we tell about health matters, and it matters a lot. The traditional story is about personal responsibility and access to doctors. That's true, but it's not the whole story. There's a much larger story that has to deal with the environments where people live, work, play, pray, particularly for low-income Americans who are much more vulnerable to adverse environmental contexts. And finally, resources matter. We have to think about leveraging various forms of capital to actually redirect that capital towards public purposes. So what's health equity? When all people have the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. That's from the CDC. Socially determined circumstances. So if we want to advance health equity, we have to think about how did we get to the situation where we have park poor communities? How did we get to the situation where we have food deserts in low-income communities? They didn't just happen naturally. These were communities that were disinvested in. And we have to understand why. And then we have to think about, okay, if we're serious about changing this, what is the role of community engagement? We also have to think about, when we're thinking about health equity, is giving voice to those that are most impacted by those inequitable conditions. This can't just be smarty pants people with a lot of degrees behind their name, like me. I mean, I'm useful, we're all useful in this, but this needs to be led by people experiencing these conditions. They need to set the priority, they need to set the agenda. And to do that, they need help. They need to be engaged in a meaningful way. Okay, so policy and politics shapes neighborhoods and resources. Let me just take you through a quick example of this, because I teach at Berkeley students. My students are oftentimes asking me things like, why don't people just leave these communities? You know, as if it's that easy. And you know, these are smart students and they're good students. But you know, I got asked that question so many times that I decided I had to make a slide about it. Okay, so I'm a lawyer, and you know, one of the things that lawyers do is we like to read legal cases. This is a legal case in Alameda County. We did a lot of research looking at sort of land use patterns in Alameda County. There's a particular clause in this case. This was a group of people who bought some land and decided to put a restrictive covenant on that land. And the restrictive covenant read as follows: no person or persons of the Mexican race, whatever that is, quite frankly, or other than the Caucasian race. Note that Caucasian is in capitals because it's important. shall use or occupy any building or any lot, except that this covenant shall not prevent occupancy by domestic servants of a different race domiciled with an owner, tenant, or occupant thereof. Now, we found these things everywhere we looked in Alameda County, and all of those maps I showed you earlier, where you find those red zones where people have relatively low life expectancies, those are the places where people had to live, that were resource poor, that were redlined, because of racially restrictive covenants and a whole host of other practices. And we act today as if this history didn't exist. Like we only have to look forward and encourage people to eat healthy and exercise more, and not look backwards and see how we created the conditions that make it impossible for them to eat healthy and exercise more. And I put it to you that that's a lack of critical thinking skills. I don't understand why we do that, but we do it all the time. We found these restrictive covenants all over the place. We know that there has been a history in this country of racially restrictive segregation that has health consequences today. This was federal policy. This is a Federal Housing Administration's guidelines, which read, it's necessary that property shall continue to be occupied by the same social and racial groups. That was in the late 1930s. This is actually ultimately made illegal by the Supreme Court in 1948, although a lot of this activity continued informally into the 1970s and elsewhere, and beyond. So the central question for us is, if we believe, if we're serious, and I put it to you that some of us are not serious. Some of us just do this because it's a job. But if we're really trying to address these problems, and we recognize the history and legacy of past practices, and some of the products of ongoing present-day practices, and we believe that this work is about social justice, then we have to ask ourselves some hard questions. First of all, one question is, what the hell is social justice? If you try to define it, oh my God, just look it up. Just trust me. This is the most complicated definition I've ever seen in my life. I distilled it down to two things. One, when we're trying to commit to applying social justice in our practice, we have to look at the first ingredient, which is truth. We have to tell the truth about what we're seeing, and we do a pretty good job of that in health and public health and philanthropy. We actually publish a lot of reports. We have a lot of data. We do a lot of research. We document life expectancy differences, obesity differences, diabetes differences. We forecast what's going to happen if we stay on the same trajectory. We're very good at trying to find the truth and to talk about the truth. I would put it to you, we don't talk about it in particularly accessible terms. Most people don't understand the truth, but we do a pretty good job of trying to get that data out. What we don't do a very good job of is actually creating the power to change the reality on the ground. And we argue in our work that really has to do, one way of approaching that is really organizing people, which is a deeper form of community engagement. It's really believing that you need to optimize democracy in the communities that are experiencing these health inequities. So justice has two ingredients. It's truth and it's power. And we have to invest in both sides of that equation. Okay, so people get frightened sometimes when we talk about power, so let's break it down. Power is the ability to get what you want. And we think about power across the spectrum from powerlessness to kind of coercive power, where people kind of use their power to actually hold other people down. We also, when we think about to get what you want, we're talking about self-interest. And self-interest can be at the community level and it can be at the individual level. Now, when we talk about power, we have to recognize that it's neither good nor bad. It's neutral. It's really how you use it that matters. It is not given by others. It's claimed or built with others. It's a product of relationship. And one of the really unfortunate things that we face in a lot of low-income communities is a lack of social cohesion. People are socially isolated. And one of the easiest ways to build community power and resilience is to actually bring people into relationship with each other, It's actually fairly simple, and it's very gratifying, I'll tell you. It's a lot of fun, and you'll hear from some of our panelists, I think, about the approaches that they've used to do just that. Power is most effective when it's focused and channeled. So organizing people, getting to their priorities, and then working on those things one by one. And finally, communities where people have strong relationships with one another are more powerful than communities where relationships are fragmented. I want to give credit to PICO, which is a community organizing group from whom I stole this slide, because I loved it. Okay, so in our work at the California Endowment, we're a health foundation. We're spending $1 billion over the next 10 years to fundamentally improve the health status of 14 low-income communities, and we're doing it by not investing in health care. We're investing in what are known as the social determinants of health because we believe that fundamentally we can prevent a lot of the demand on the healthcare system if we effectively invest in creating healthy communities. And one of the key strategies that we use is organizing people. And you don't have to go to California to find it. Right here in Colorado, we've got Together Colorado and some other organizing groups that are doing brilliant work. Some are being funded actually by the Federal Centers for Medicare and Medicaid. The Bridges to Care program, which is in Aurora, Colorado, not too far from here, which is a product of Together Colorado and a primary care network and Aurora Mental Health. Got $3.3 million from the Center for Medicaid and Medicare Innovations to implement a hotspotter model. This is the Jeff Brenner model that comes out of Camden, New Jersey, which recognized that the healthcare system can't deal with so much of this social burden of disease. And in fact, we have to start looking at social supports and strategies to prevent the healthcare outcomes. I think you're going to hear a little bit about that from some of our panelists coming along. The point of this is that when we say community engagement, we're talking about community engagement towards an end. Community engagement that actually serves the purpose of reducing the burden on the healthcare delivery system. And we should stop trying to solve problems in the healthcare system that really are better addressed at the community level. And if you want to address these problems at the community level, you have to organize people. And as I said earlier, fundamentally, you just have to have a belief that democracy works, because this work is really about optimizing democratic processes. Okay, so there's a historical narrative in this country that is really about redlining policies, racially restrictive covenants, land ownership rights, Medicaid. I mean, I argue, I probably shouldn't say this publicly, but I say it publicly all the time. The Affordable Care Act pushes a lot of people into Medicaid. Medicaid is a broken system. Medicaid is a second tier or third tier system. So we're actually enshrining inequity into our healthcare system through the Affordable Care Act. Now look, it's better than people not having insurance. It's better than the status quo. I'm not arguing that. All I'm saying is, why are we pushing people into a second-class system? Why aren't we putting everybody into a first-class system? I mean, what does that say about us? Social Security policy for a long time excluded farm workers, excluded domestic servants, intentionally because it wanted to exclude blacks and others. Affordable housing policy, we know, is a long checkered history of segregating. A bunch of practices that we're aware of in the historical narrative about racial segregation that created inner cities, barrios, reservations, Chinatowns. And today we have predatory lending, immigration policy that is exclusionary, incarceration policy that's disproportionately impacting certain groups, school push-out policies which are expelling and suspending hundreds of thousands of kids and putting them on the school-to-prison pipeline. Up until fairly recently, same-sex marriage or marriage equality was a big issue, policy issue in this country. The common denominator behind all of these policies is exclusion. And so that narrative is basically creates a lot of trauma. It isolates people. It leads to internalized depression and self-hate, quite frankly. And it leads to, I think, the greatest tragedy, which is wasting human potential. And that's the one thing this country can't afford to do. We've got talented people out there living in low-income communities that, they're literally the next Bill Gates or Elon Musk or whomever. And we're not developing their talent. We're losing competitively to other countries as a result of that, because we warehouse people. It's very expensive to warehouse people. We end up spending and breaking our budgets both in the healthcare system, and the criminal justice system, and the foster care system, and social services, because we haven't made strategic, low-cost investments in developing that human potential, because of this narrative of exclusion. And so the question is, what do we owe this kid in this community who's growing up, who didn't create any of this? What is our role? What is our responsibility to try to create an environment where he and others that are similarly situated can participate in a meaningful way and not ultimately become a burden on the social services and health system? So we need a new narrative of inclusion. So let me conclude here by taking you through a framework, because I'm a public health nerd and we have to have frameworks. And this framework is basically a compound framework. It's referred to as the Bar-High model, or the Bay Area Regional Health Inequities Initiative model, which is a very simple framework. It doesn't explain the universe, but it helps us target interventions at root causes. And it starts with this sort of downstream medical model where, I went to Johns Hopkins Medical School, where I learned, at the time it cost about $100,000 to go to medical school. Now it costs like $100,000 a day, I think. But for $100,000, this is what I learned, and that was that bad behaviors produced disease, which produced premature death. So our role in healthcare was essentially to change people's behaviors and intervene in those diseases. And that's a simplified medical model. Our leverage points were what people knew, their access to healthcare, and to some extent their genetics. And we've found since that time that the story is much bigger than that, and that there's a larger socio-ecological model that actually creates this downstream cascading demand on the healthcare system. And it starts with a narrative, and that narrative is really historically, although it's changed dramatically, but there's still remnants of that historical narrative of essentially excluding various different groups of people based on a set of isms, prioritizing certain people's needs over others because certain people were considered to be more valuable than others. I mean, that's what it boils down to. And that led to a set of institutional practices that essentially created policies that favored certain groups and disfavored others, which left certain people facing profound social inequities. And those social inequities manifest themselves to some extent in communities, in workplaces, in other kinds of experiences that certain groups that aren't necessarily geographically located, like gays and lesbians, experience in their day-to-day life. And those inequities actually make it much more likely that they will experience disease. And then that disease cascades down to premature death. So understanding that is really understanding that if you want to focus on health disparities, you work in the healthcare system. Downstream, if you want to focus on health inequities, you work at the community level. And understanding how to intervene at the community level is very different than intervening in the healthcare system. You can take the word health out of this equation and just look at inequities producing disparities, or if you're simple-minded like me, you just talk about conditions producing consequences. And we spend $3 trillion on consequence management. Sometimes I refer to it as damage control in this country. I spent most of my career doing it. I still see it as incredibly valuable. It's necessary, but it's not sufficient. And so the question for us really is to try to understand, when we're spending that $3 trillion, how to drive some of that cost down by actually making investments in prevention, in real health. And that's what this panel is going to talk about. Right now, at the nexus between the upstream and the downstream, we have a fair amount of community engagement going on. I would argue it's a little self-interested. It's mostly the healthcare system trying to get people to use the healthcare system more appropriately to the needs of the healthcare system. It isn't deep community engagement. What we need to do is to spread community engagement across that whole upstream spectrum. And what we hope is that this panel will give you a flavor of that spectrum and where there are opportunities for community engagement across the entire spectrum. To conclude, the medical model says that bad behaviors produce disease, produces death. And the socio-ecological model says that basically you have biased beliefs or bad societal behaviors that produce policies and practices that produce neglected communities that end up being on life support. And we have interventions to try to prevent death. We call them emergency rooms. We have interventions to try to manage disease. We call those clinics. We have interventions to try to change behavior. We call that health education. What we don't have are great interventions to try to improve the status of neglected communities. We have one at our foundation called the California Endowment. We call it Building Power in Place. It's about building social, political, and economic power and a critical mass of people living in these communities to change the status quo dynamics. We think that's not sufficient. We think we have to intervene at the policy level as well with policy advocacy, and that we have to change the narrative about what health is and what it is to be American and to pursue the American dream. So our end state is really a state of inclusion and a narrative of sustainability, policies and practices that reflect health across the board, and then resilient and transformed communities. And so the interventions are intervening on the social determinants of health, and the critical ingredient in all of those interventions is community engagement. I'm going to stop there and introduce our first speaker. So our panel